Bismillah ar-Rahman ar-Rahim. First of all, good morning if it's morning, or good night if it's night. And what I'd like to do today is to go with you about 30 minutes through some principles of diabetic medications. And I will talk about practical cases about different types of families of anti-diabetic medications, of course, without insulin. So, this is a very nice scene, and actually, this is when or where the metformin comes from. And it was used for a long time to decrease diabetes, even before the metformin was synthesized. And then, of course, it was taken out to be very well calibrated and dosed. Now, in this presentation, what we want to do is to discuss something which is really important. And to see here, there are many patients which have different changes or different weight and ages. So when you have a diabetic patient, he might be obese, he might be young, she might be a female. So for everybody, we should individualize the medication which actually works for this specific patient. Now, about diabetes, is it common? Actually, if you see four in Saudi Arabia, four people, one of them is most likely diabetic. And this is because Saudi Arabia is considered #1 country in the whole world in diabetes prevalence. If you see here, you see number 7, Saudi Arabia, 24%. But actually, if we see the 6 before, they are not real countries. If we, 2 kilo is 1,200 population. So it's just like, a small town. So basically, if we see through the countries, Saudi Arabia will be #1, Kuwait #2, and Qatar #3. When we talk about diabetes, we need always to remember that diabetes is not polyuria or polydipsia. Somebody goes to the bathroom. Diabetes is something much more than that. Diabetes is #1 cause for kidney failure, heart disease, the blindness, amputation, just the second cause after trauma, amputation of the lower limb. And at the end, if somebody has diabetes, the risk of stroke and CVA is much higher than non-diabetic patients. But much worse, after 20 years of diagnosing diabetes mellitus, the risk of being dead is about 4 times in a woman and 2 times in a man with diabetes compared to non-diabetic. Now the question is, if we have all these problems from diabetes, is there a cure or not? And the answer is very simple, and it came from UKBDS, that even a very small reduction of hemoglobin A1c, like 1% only, will decrease the microvascular complications up to the third. So we are decreasing third of microvascular complications only by reducing hemoglobin A1c by 1% only. So this is really very important news. But what about the macrovascular complications? Macrovascular complications also decreased. As you can see, all-cause mortality reduced by 27% in metformin group, by 13% in sulfonylurea group in UKBDS after 20 years. But this was started just when the patient was diagnosed as type 2 diabetes. So if you want to prevent macrovascular complications, we should start the control very early since the diagnosis. Don't wait a long time. Now, let me ask you a question here. What is the hemoglobin A1c target? Okay, hemoglobin A1c target for most of the people from many associations like American Diabetic Association is less than 7%. Why? Because less than this, all complications of diabetes are, of course, near normal. Now, we need to individualize patients. If a patient is 80 years old, or he has terminal cancer, or somebody who's not expected to live long for any reason, what we need to do is to make the hemoglobin A1c acceptable, about 7.5 to 8, to prevent the acute complications like or symptoms like polyuria and polydipsia. Okay. At the same time, when we say 7.5 to 8, we need always to remember to add without hypoglycemia. Less than 7 without hypoglycemia. If you have somebody who's young, like this patient, if you're unlucky and have this patient in your clinic, again, we need to have hemoglobin A1c between 6 to 6.5 without hypoglycemia. Now, suppose we have a newly diagnosed type 2 diabetes patient, 47 years old male, new type 2 diabetes. He comes to you in the first time since diagnosis. What is the first treatment? The first treatment always is lifestyle modifications. Our lifestyle increase the weight and increase the blood glucose and the blood pressure. So we need to start the lifestyle modification, which is actually movement about 10,000 steps a day or 3 hours a week, in addition to very good diet. Now, the real problem with diabetic patients, they don't know what to eat, and then of course they will eat everything because they have an idea that they should not eat anything. Actually, the diabetic patient should eat just like anybody else, which is the healthy diet. What is the healthy diet here? This is something called the diabetic plate. It's about 9-inch, which is the regular plate. You will put half of it as vegetable, and the other half you will divide between proteins. One day meat, one day fish, another day is something like chicken, and the lower part will be starch. He can eat rice or pasta or brown bread, but of course always brown and complex carbohydrate are much better than the simple carbohydrate. Regarding the fruits, every diabetic should have about 2 to 4 fruits a day, depending on his weight. Any type of fruit. He can eat mango, or he can eat melon or sweet melon, or grapes, in addition, of course, to milk. So he should be healthy like anybody else, and he should have a well-balanced diet. Now, the new recommendation since 2007 states that any new diagnosed type 2 patients should start in metformin right away with the lifestyle modification. And why is that? Because we know after 20 years, there is a reduction of mortality, there is a reduction of all microvascular complications, and we should start, of course, with the diagnosis of type 2 diabetes. Now, it's the first choice always. Some people will have GI symptoms like discomfort, so we'll start low, like 500 milligram once a day, and then go up. The maximum effective dose, the max is 2 grams per day, which is 1,000 twice a day, or 853 times a day. Or if you want to use the new extended release, you can use 750, 2 tablets together after the last meal. Now, the new recommendation states we need to avoid metformin only if the GFR is less than 45. The risk of lactic acidosis with metformin is very low. It's not like, of course, metformin, which is the old one. And at the same time, these cases of nephropathy were seen only if there is use of contrast. Now, what is after metformin? This is $1 million question, actually. And why is it $1 million question? Because nobody knows exactly what is the best medicine to start after metformin. Now, to choose a medicine, we need to have that type of medicine which has good control, but at the same time, there is no weight gain, because weight is the main problem of diabetes, and also there is no hypoglycemia. Let's see what's the difficulty of hypoglycemia. If somebody has severe symptomatic hypoglycemia, after 1 year, the likelihood of being dead or the mortality is 20%, which is really very high. But suppose the hypoglycemia comes to a pilot. He will be dead, and the whole plane will be dead, of course, at the same time. Now, according to the risk of hypoglycemia, we can divide the medications into two groups. The high risk of hypoglycemia, which is basically sulfonylureas, and the low risk of hypoglycemia, which is all other oral medications. Let's start with a very practical and everyday case. We have this Mr. Omar, he's 55-year-old truck driver. He has type 2 diabetes. He's already metformin 2 grams per day, and his hemoglobin A1c is uncontrolled 8.5. Remember, we said that we want it below 7%. Okay. Now, what is not to use in this case? Sulfonylureas, pioglitazone, or incretin. Just going back, we remember that he's a truck driver. So we don't want to use anything which might cause hypoglycemia, and of course, he will be involved in accident. So this will tell us that there are many people we should avoid sulfonylurea because they are high risk for hypoglycemia. A pilot, a driver, somebody who fasts 2 days a week or 3 days a month, somebody who works in a field like a farmer or something alone, he might have hypoglycemia and have coma and nobody knows about it. Somebody who lives alone, or for example, a shift worker who miss meals, 75 or 85 years old, any patient with eating difficulties like cerebral palsy, or any patient which cannot take food if there is nobody around. In all these, we need to avoid hypoglycemias, and at the same time, of course, we should not give sulfonylureas. Now, this is a real case which was seen. This is a patient who was admitted the first day because of hypoglycemia. He was picked up by one of his family who visited him. He lives alone, and the blood glucose on D50 was 83, but after that it went down to 40, and after 24 hours is still 20 while he is in D50. So the risk of hypoglycemia is high, and at the same time the duration is really very long. It can stay up to 72 hours with some sulfonylureas, though there are the new groups of sulfonylureas like gliclazide or glimepiride are less hypoglycemic than the old ones. Now, hypoglycemia leads to something else, of course. Leads to eating because of the patient will be afraid to have hypoglycemia. So he will prevent hypoglycemia by more food, which means that he will gain weight, and at the same time, of course, we know that all medications of diabetic medications will increase weight. And actually, these are the old medications. Even metformin on the long term, in UKBDS, the patients had weight. The new medications, as you can see here, DPP4 inhibitors, metformin, GLP-1 receptor agonist, dapagliflozin, all of them did not increase weight. Either metformin, for example, the weight before DPP4 inhibitor also maintain the weight, but we have dapagliflozin and GLP-1 receptor agonist might also decrease the weight. Now let's see another patient. This is a 62 years old female. She has type 2 diabetes, and she has congestive heart failure, bilateral lower limb edema, and she's already in metformin 2 grams per day, and her hemoglobin A1c is uncontrolled, which is 8.5. Now, the next question, in this specific patient with CHF or congestive heart failure, what is not to use? Sulfonylurea, pioglitazone, or incretin? Of course, in this case, pioglitazone will increase the risk of edema. Now, this tells us that we need to avoid pioglitazone if there is edema because of any cause, congestive heart failure, liver cirrhosis, nephrotic syndrome, and if there is, of course, high-risk postmenopausal osteoporosis or chronic urinary bladder disease. But this does not state that pioglitazone should not be used in other patients. Pioglitazone is a good medicine which has a very bad review in the last some years because of increased number of bladder cancer, which was very minimal. Now, suppose you have a patient who has abdominal gases. And this patient, of course, will not going to use acarbose. Acarbose will increase the abdominal gases. And actually, in one study, 80% who started on acarbose stopped this because of increased abdominal gases. Okay, now let's move to another class of medication, which is called incretin. What is incretin? It's intestinal secretion of insulin. So this is the intestinal secretion in response to insulin. And the whole idea is if you eat sweet, your blood glucose will go up, and at the same time, your insulin will go very high. But if you have D5 introduced into your body, your blood glucose will go up, but at the same time, the insulin will go much less. So the difference between this is called incretin effect. Now, incretin effect is much less in diabetic patients because they don't have the incretin. What is incretin? Suppose you are eating sweet, okay? Now, there is a stimulus will go to your intestine to secrete glucose or glucagon-like peptide. So GLP-1, okay, will be secreted, and this will have many actions at the same time. But the main two actions is increase insulin and at the same time decrease the glucagon. And if you see, this is the first one, which will decrease glucagon, which is a real problem in type 2 diabetic patients. Now, what is this is the very good thing about the incretin. What is bad about incretin? Incretin, like GLP-1, is very short half-life. It's about 2 minutes. So at any given minutes or at any given time, 80% of GLP-1 will be inactive. Okay. Why it's inactive? Because there is an enzyme called DBB4 will deactivate it to make it inactive GLP-1. So if you want to use this in a treatment of type 2 diabetes, we have one of the two things, either to give GLP-1 or to inhibit the DBB4. And actually, we have two types of groups or medications, the GLP-1 and the DBB4 inhibitor. Now, the real good thing about these two groups, the first thing is incretin, which is GLP-1 and the DBB4, incretin does not cause hypoglycemia since it secretes insulin after eating only, okay? And incretin also does not cause weight gain. So this is a very good, which is good control, no hypoglycemia, and no weight gain. So how come there is no increase in insulin except after eating? It doesn't sound actually very logic. Let's see. This is as you can see, the GLP-1 receptors and GLP-1 receptors. The GLP-1 will attach to the GLP-1 receptors and work there to increase insulin secretion. But the receptors will be inhibited in case there is hypoglycemia. So the two groups we have in this GLP-1 and DBB4 inhibitor. The GLP-1 is injection, DBB4 inhibitor is tablet. The GLP-1, there is weight loss. In DBB4 inhibitor, there is no weight loss, but there is also no weight gain. The GLP-1 is expensive. So you can get whatever your patient actually need, and you know what are the differences between the two groups. Let's start now with a new group, which is completely different, and nobody thought that it might come in a time. For a long time, we are talking about urine and glucose. if there is glucose which is filtered in urine, and if there is high glucose in urine, we used to say that this is something which is really very bad. Now, the glucose usually will be filtered through the kidney, and in the proximal tubule, there is something which is called sodium glucose transfer 2. It will reabsorb 90% of the glucose. And after reabsorption, of course, there will be increase in glucose. This will be maximized in case of type 2 diabetes. But at the end, we have minimal glucose excretion. Now, the new type of medication, which is called the SGL2 inhibitor, it works through these SGL2, and then instead of going out, this will go and continue to be secreted through the urine, okay? And of course, there will be more urine, glucose in the urine, and less glucose in the blood. The good thing about this group also, it will decrease sodium, which might decrease the blood pressure. And of course, because the 180 gram filtered of glucose, there will be something which is about 70 or 90 grams, which is secreted. There will be a weight loss because of less glucose and less calories. By this, we actually covered most of the medications or diabetic medications. And to go through in the summary, we need to remember that we need always to individualize. We need always to individualize patient, okay? Now, when you individualize patient, you have your patient who's obese, another one which is a female, somebody who has recurrent UTI. So always you have somebody, you should individualize the medications. We have different medications. We are lucky to be at this time of treatment of diabetes mellitus. And of course, we are talking about type 2. And we need to individualize. And after that, we need always to have a very good control and to avoid weight gain and avoid hypoglycemia. In a very short summary, we need to remember that when diabetic patient is diagnosed, we need to start lifestyle modification with metformin at the same time. First choice, we start low, maximum effective dose will be about 2 grams per day, and avoid GFR only less than 45. Now, if we want to use sulfonylureas, we need to remember that there are some groups which are highly prone to have hypoglycemia because they fast, or if they have hypoglycemia will be in real danger because they are alone. We need to avoid sulfonylureas in these patients. The third group is, of course, the bioglitazone. And in bioglitazone, always there is, of course, there is 5%, not always, there is 5% increase in edema. So if there is somebody who has edema, like from CHF or liver cirrhosis or nephrotic syndrome, we should not use them. High risk postmenopausal osteoporosis, because there is increased risk of osteoporosis, and chronic urinary bladder disease. In incretin, just a very rapid review. When you eat sweet, there will be GLP-1 secretion from the intestine, which will increase insulin and decrease glucagon. And at the same time, it does not cause hypoglycemia. It does not cause weight gain. And this is the summary of the medications. Individualized, individualized, and individualized. Thank you very much.